Well, welcome everybody. I never thought I'd have a chance to present at this meeting because I don't do bench research and I don't do high-powered clinical research. This is very different. This is education research, and in fact, it's qualitative research, which may be unique for this, and I hope you enjoy it. This is called Narrative Medicine, Novel Elective in Pediatric Oncology. Most of the speakers are joining me are three students, and I'll introduce them in a few minutes. There we go. We don't have any conflict of interest for this talk, anything relevant anyway. So I'm going to start, introduce the topic, the elective, and how we did the research on it, and then I'll have the three students, Jeff, Matt, and Maria, give their portion of the research they did, and then I'll come on for some final thoughts at the end. So I'll start here. So this is about narrative medicine, an elective in pediatric oncology that we've been running since 2008. It's an elective that takes 1 to 2 students at a time. It's a 2-week elective in pediatric oncology, and it's very different than most clinical electives. The idea for this came years ago. We used to have, and I think we're going to start again, having high school students and college students shadow us. And what I would do when I would get one of those students with me is I would walk them out to the waiting room and I would introduce them to one of our oncology patients who had just checked in, and have that student follow the patient and family through the clinic experience to start with. So they would see the patient check in, get the vital signs, get the port access, and then go wait for the room to be ready, go in the room and see the doctor. And that way they would get to see that side of it first, and for the rest of the day they would shadow me. And I thought that was a nice way to have them get a perspective on the field as a whole, not just from the doctor side. So I thought about in 2008 when they opened up, they invited divisions to have medical students do electives with us. I thought of doing the same thing. So I take these students and place them with a family or several families over a 2-week period, and they shadow those patients and they keep a journal for me. And the goal is to have them see several different kinds of patients. They hopefully a new diagnosis, they can see that process. And one of the things I like them to see is the admission process. So patients come in and then they wait for a bed, they go up to get a bed and they get their chemotherapy. So they get to see what patients experience. And that's something that students never get. And I designed this just for a student experience. I never thought that I would do research on it. But after all these students started doing this, they'd each send me this journal. I would read the journal. I always liked what I would read. They were very interesting to me. And after 12 years in 2019, I had a collection of 120 journals from these students over the years. And I went, I had heard Dr. Dellasega speak about qualitative research. And so I approached her with these journals and said, well, would this be a good project to do, to look at these journals and look for themes? And she read a few of them and she agreed that it would be. And I want to thank her for the work she's done. I take credit for the elective, but she's the one who ran this research. She trained the students. She ran the meetings. She trained them in qualitative techniques, and through an iterative process, we came up with these themes. And it's more than just I thank her for, we couldn't have done this without her. She really did this research, and I helped out a lot. And the students did a tremendous amount of work. They had to read each one of them read all 120 journals, over 500,000 words, and through these meetings came up with the themes that they're going to discuss today. So the students have specific instructions, and I'm going to read this so that you can see what each of the students was tasked to do during this 2 weeks. So this is a unique 2-week elective designed to introduce the students to the pediatric hematology and oncology experience, both from the physician and patient perspectives. The student will follow longitudinally several oncology patients at different stages of treatment, but instead of from the medical side, the goal will be for the student to gain insight into what patients experience, not only with their illness, but also with the system that treats that illness. The student will spend extended time with these patients and their families. Examples of patients that may be followed include during initial diagnosis, newly diagnosed patients starting chemotherapy, seasoned chemotherapy patients, and off-therapy patients in follow-up. And then the student will keep a journal to be turned in at the end of the rotation. Through the journal, the student will communicate what he or she has learned about how patients and families deal with a cancer diagnosis, but also with the positive and negative aspects of the medical system they need to navigate for a cure. And I left the length and content and style of the journal up to the students so they wouldn't be burdened by doing it a certain way. And the only requirement for the elective was to turn the journal in electronically to me at the end. I designed this with the help of Dr. Blackall, and he met with all these students at some point to talk about the psychosocial aspects of cancer in children. And now I actually have the students meet with our chaplain as well. So that's what they would do. They would also spend some time in clinic with me, and I would debrief them periodically during the rotation. So again, in 2019, I approached Dr. Dellasega with the journals. What we did is we picked 4 first-year students for their medical student research projects, and they did a qualitative analysis on the first 100 journals we'd collected since 2008. Since it's educational research, it's IRB exempt. I participated in the meetings, but my big job was to de-identify the journals. I removed all patient identifiers, all names of the students, and then I took all the journals and I randomized them in order so the students who analyzed the journals would not know which ones were written in 2008, 2012, 2018, and so on. And then we had these 4 students guided by Dr. Dellasega who read each journal, and each one picked a theme to be taken from the journals. So I want to point out that there are 2 groups of students that we're going to be talking about. First of all is there's 119 students because one of them took the elective twice, but the students were mostly third, a few 4th-year students who actually took the elective and wrote the journals. And then there's the 4 students, 3 of whom were here today, who analyzed those journals. They were first-year students when they did that work. They're now 4th-year students themselves. So Jeff will go first, and his theme is developing empathy.
Thanks, Dr. Freiberg. Good afternoon, everyone. I'm Jeff Lorenz. Thanks for the opportunity to speak today on our research. This is a project that I'm sure you can tell that we're all passionate about, and we hope you enjoy it. So the title of my research angle is a novel elective in pediatric psycho-oncology and narrative medicine to combat empathy drift in medical students. Next slide. So some learning objectives for my talk are to appreciate the value of experiential learning methods in medical education, including those that are unconventional, to cultivate empathic attitudes in students, and to justify the use of narrative medicine as a tool to make meaning of emotionally challenging experiences and reinvigorate empathy in medical students. So I'll start with a quote. The patient is a 15-year-old female with late relapse T-ALL, undergoing chemotherapy with plans for a stem cell transplant. She had been hospitalized for fever and was undergoing a workup for the source. What does this sound like to you? As 4th-year medical students, Maria, Matt, and I know the fundamentals of a history of present illness portion of a patient chart as well as anyone. This is a clinical and detached summary. And just like this format, pathophysiology and presentation, pharmacology and treatment are objective and concrete. It's been ingrained in students in the healthcare profession to figure out what's happening, what the diagnosis is, and fix the problem. Next slide, please.
I'm trying, it's not going. It will in a second. All right. There we go. Is that it?
Yep. So here's another quote. The first patient I met on rounds during my pediatric hematology oncology rotation quickly reinforced the fact that I need to be more conscientious of my actions as a medical provider. Her name was blank, a 15-year-old female with no hair, sitting up with her concerned mother at her bedside. She has late relapse T-ALL and is undergoing chemotherapy with plans for a stem cell transplant. She had been hospitalized for fever and was undergoing a workup for the source. I instantly became overwhelmed with grief over her situation and slowly realized how much the patient's disease not only affected her, but also dramatically impacted her family and friends. So what do you notice that's different about this? The information conveyed is still the same. However, there are introspective and empathetic components present, which I've highlighted in blue, that are absent from the other. Next slide. Empathy is an essential component of the medical school curriculum. However, there is no single school of thought on how to interpret, exhibit, cultivate, or preserve it. Preparing empathetic practitioners is a challenge, but important to consider since empathy is an attribute that allows practitioners to understand and communicate emotions in a way that patients can see and value. In the clinical setting, it is a determinant of high-quality healthcare that can improve patient outcomes and has been associated with higher ratings of patient satisfaction. Next slide.
It's just not responding right away.
No worries.
There we go.
So while the positive effects of empathy are far-reaching for the patient-doctor relationship, loss of empathy and patient-centeredness weakens this connection and is associated with physician burnout. This contributes to a deterioration in the quality of care that includes an increased rate of major medical errors. It is common to see first-year medical students enter with optimism and hopefulness that eventually devolves into a cynical view of medicine that continues into residency and beyond. So we define this topic as empathy drift. And we understand the Jefferson scale of empathy is an existing validated measure to statistically analyze empathy. However, in this study, our goal was to gain a deeper understanding of what contributes to it through narrative. Next slide. There's evidence that empathy is a skill that can be taught, learned, improved upon, and continued. One such strategy is utilizing aspects of what's called psycho-oncology. Shadowing patients and their families through their cancer journey allows students to gain unique insights into multidisciplinary care and is a strategy that enables them to readily adopt the patient perspective. Next slide. Another strategy to facilitate medical student professional development is narrative medicine, which involves structured reading and writing assignments that enhance how students make meaning of their encounters with patients and colleagues by interacting, listening, and expanding their view of patients. By using narrative to immerse students in the illness experience and the emotions that come with it, students are better equipped to adopt the patient perspective in future practice. Among the positive effects of its implementation is enhancement of empathy in students. Next slide. So the aim of this study was to evaluate the impact of an educational elective, which provided students with the opportunity to engage with pediatric oncology patients and their families over an extended period. And so our question was, what is the impact of this novel elective designed to combat empathy drift? Next slide. Consistent themes emerged related to developing a rich understanding of patient and family experiences, a humanistic appreciation of the context of illness and crises, the ability to meaningfully reflect on insights and reactions to critically ill children, and an appreciation for the unique learning opportunity. In addition, patients and families expressed their gratitude for the students' attentiveness to their emotional needs. By the conclusion of the elective, most students discovered that they had reignited the intrinsic impulse toward empathetic behavior and were provided with beneficial insights that they felt would follow them and enhance their practice in future rotations. On the following slides are select quotes that were written by students in their journals that demonstrate these themes. We have obviously many. Next slide. By living with the pediatric oncology patient and family experience in this elective, students were provided with firsthand insight into how patients engage with illness, family, and the hospital system, and felt the same uncertainty that patients felt. One narrator noted, "How will this diagnosis be affecting this family in the long term? What sacrifices will they have to make along the way? How will this affect the family financially in the long run? Will the patient's mom have a job to go back to? Will blank be able to cover the majority or all of the medical costs? Next slide. Comprehension of emotional needs allowed students to discover their niche role and gain a humanistic appreciation of the context of illness and crises. By the end of the rotation, many appreciated that caring for a patient is more about being there than actually being able to change anything in terms of their disease. One student explained, "In the beginning, I felt like I was meddling when I would start to follow a child because I felt like an outsider, just watching, not doing. By the end, these patients had become my own. Even though I wasn't treating the patients per se, I was involved in the healing process." Next slide. Through this immersion experience, students were able to meaningfully reflect on insights and reactions to critically ill children. One narrator commented, "Dr. Blank is explaining the appearance of the slide, pointing out good examples of the Reed-Sternberg cells. I'm entranced, excited, but walking back to the waiting area where the patient was lying, I felt guilty. The exciting cells are malignant. The patient is sick, and this is the answer his parents were waiting for, but not the one they really wanted." Next slide. Students appreciated the additional time that allowed them continuity of care and the opportunity to form stronger patient relationships. One student wrote, "I felt as though it would be beneficial to get to know him as a person first and then as a patient. This approach is very different from how I've gotten to know most of the other patients I have cared for." Most students acknowledged that this unique rotation rejuvenated them at a vital time in their development, as evidenced by this entry. "For me, this rotation came at a crucial time. Blank year is an exhausting year with little time for reflection, and it's very easy to become burned out and numb to the humanistic side of medicine. Patients truly are the best teachers, and I'm thankful for every lesson that they have taught me." Next slide. So we concluded that a model of immersive training combined with narrative reflection, although emotionally challenging, may be effective in counteracting empathy drift in medical school. By cutting ties with the provider point of view to focus on the patient, students were able to appreciate the therapeutic value of comprehending the social and personal experience with illness. For educators, similar curricular activities should be considered as an important next step towards restoring empathic behaviors throughout the entirety of medical school. So next slide, please. So I'd like to leave you with a quote that I think embodies the elective. "I will take even just a second to step out of the busy day and constant to-do lists to really look at these patients and try to put myself in their shoes. I will resist the urge to dehumanize them to a medical record number of a list of problems we need to fix. I will never forget that a little boy or little girl is fighting for their life in the next room, and I will never give in to the cynical and hopeless nature that plagues our profession." Next slide. Thank you. If you're interested in finding out more about this topic, you can check out our manuscript, which is in the Journal of Cancer Education. Now I'd like to turn it over to Matt.
Alrighty, thanks, Jeff. Hi, everybody. I'm Matt. I'm going to talk for a little bit about the next theme that we encountered in these student narratives, which was uncertainty. And more specifically, how students grappled with and learned to make meaning of the uncertainty they experienced on this rotation. So we go to the next slide. Yeah, so I think we all know that uncertainty is felt by everybody in a healthcare setting, both providers, but also patients. And for providers, which all of the students on this rotation are going to one day become, even if uncertainty can be reduced through years of experience and practice and rigorous study, no medical decision really is going to be made without some kind of element of uncertainty. There can be different sources of uncertainty. Some of those are technical, related to understanding information and making actual medical decisions. Other sources of uncertainty can be personal, like how to best interact with different families, how to build that doctor-patient relationship and build trust. So it's been shown that the inability to cope with feelings of uncertainty actually lead to worse patient outcomes, as well as worse outcomes for providers. So examples of poor outcomes would be increased stress on the provider, higher rates of burnout, and those sorts of things. So the other side of this obviously would be then when uncertainty is embraced, research has shown that there's a fostering of curiosity rather than an avoidance of what is unknown. And this can result in better clinical reasoning by physicians. So though we know medical school obviously has a significant role in helping students learn to embrace both present and future uncertainties, there's not really much known about how students learn to cope with feelings of uncertainty in their training, and really how these experiences evolve with more clinical exposure. And so if we go to the next slide, our aim that we're looking at specifically in this branch of the research was, can an elective in pediatric psycho-oncology and narrative medicine help medical students make meaning of and even learn to embrace uncertainty? So next slide. So yeah, Dr. Freiberg and Jeff already talked quite a bit about how narrative medicine was used to gather qualitative data from these student journals about how students perceive the rotation. I'll just share a sample quote about the kind of uncertainty that I was looking for when I was reading through these journals. So one student wrote, "I saw her unbraiding her hair, which came out in clumps. As a teenager for which appearance is of utmost importance, I can imagine how difficult it must be undergoing such drastic changes. I struggled with ways to respond to awkward moments of silence." As you can tell, the student is struggling with something that really can't be taught in a didactic setting. And similar questions and struggles were posed by many students in their journals, and these were the kinds of comments that I was looking for and seeing how they changed throughout the course of each individual journal. So next slide. Yeah, students encounter many different types of uncertainty, both from their own personal feelings as well as situations that they perceived in patients and parents. Both parents and the patients had real struggles they were going through, and a lot of students tended to write and focus on the uncertainties that they observed in others. So, for example, many older patients undergoing treatment really worried a lot about the future, uncertainties regarding the future, how the loss of their previous identity would affect things going forward. Parents had to worry about caring for their sick child, as well as how they were going to raise and care for other family members, and sometimes opened up about these uncertainties to students. So students tended to write about a lot of these things. And students themselves were also, asking a lot of questions like, how do I interact with struggling family members? How do I, interact with kids who are so sick? Am I being intrusive during this deeply personal time for the family? What really is my role here? And all of these things kind of revolve around that central question, from just different angles. How do you deal with a cancer diagnosis? And the weight of this diagnosis carries with it a lot of unknowns naturally about the future. And students were kind of thrust in the world of cancer and had to watch it unfold from the bedside. So these journals helped us get an insight into some of the struggles they experienced. So if we go to the next slide. Here's a few examples of student uncertainties, either perceived or that they felt themselves. This first one is an example of a student observing or reflecting on a parental uncertainty. So the student wrote, "She," that being mom, "told me that the most frustrating part of the entire situation is the uncertainty. She had so many questions built up that cannot be answered with the current information collected, and she will have to wait quite some time before the entire picture of her child's illness can be revealed." This was obviously a student working with a patient who was, still undergoing a diagnosis. This next one, a student wrote, "I felt helpless and wished so deeply that this was not happening to her and to her family. The raw fear of death was the most overwhelming to me as a student, with little to offer at this point. I couldn't imagine how terrifying the experience was with the diagnosis, but no insight yet into the prognosis, treatment, or plan." So that's kind of a student being a little bit more introspective and kind of putting themselves in the patient's shoes rather than just talking about the uncertainties that they observed. And also, how do you interact with families going through such struggles? And this final example here, I just thought was pretty potent. A student wrote, "I just sit and try not to make things worse with my presence. I feel like I fail." So if we go to the next slide. this is just like a little bit of a model then of how we saw these kind of sentiments change throughout the journals. Initially, in a lot of students' writings, feelings of uncertainty, whether observed in parents or felt based on the student's own presence in the situation, led to feelings of really awkwardness or feeling just like an intrusion in a very intimate time in a patient and family's life. For students that want to feel helpful in a clinical situation that have kind of been conditioned to find ways to help on a medical team, it resulted in really feelings of helplessness, feeling that they didn't know why they were there, and trying to figure out what their role was in these situations. If we click to the next slide, we'll see though that over time, as students became closer with the patients and the family members, those feelings of uncertainty about their role kind of led them to find new ways to connect with patients. Many students noted that, it was things outside of the typical medical student responsibilities. It could be taking an hour to listen to, a mother talk about all the signs that she is beating herself up over that she missed. That she, could this have been diagnosed sooner? It could have been playing bingo with some of the younger patients. It could have been playing video games with older patients. All of these things really helped students to make meaning of that uncertainty they were experiencing. And it taught them that they can still actually help patients even without directly helping to treat their cancer. So we go to the next slide. This was from the same journal, and it was the quote I had read earlier about the student that said, I just sit and try not to make things worse with my presence. I feel like I fail. She was paired with a 12-year-old girl who was undergoing all kinds of workup, was not yet diagnosed. There was all kinds of family coming in and out of the room. And the student basically wrote about how they wanted to curl up in a corner and not be a part of that situation. It made them very uncomfortable. A few days later, however, we read kind of a different side of things. That same student wrote, I have to believe that the younger, freer, and patient I had met just this week is somewhere in there buried beneath. I decide it's my mission to draw her back out today. Eventually, I get her to laugh again by helping her to make a face for her IV pole. She succeeds in crafting her very own minion, and she names him Bob. At another point, this same student had written that they then, in helping kind of bridge a gap between the patient's concerns and family's concerns and medical team's concerns, this student had written, I feel like I have reason to be in the room. So we can see that the student starts to make meaning of their experience and find ways to be helpful, even though they're not treating the patient's cancer. So if we go to the next slide, this is just kind of a quick summary of how these journals help us to learn about what students gain from this elective. I thought this was a really good quote. It's a little bit long, but this student at the end of their journal wrote, I personally have experienced a wide range of emotions during this past week. I have felt helpless at times when patients or when parents have so many questions unanswered and I cannot give them the answer they're looking for. This has motivated me to go home each night and read as much as I can on the patient's illness or the potential diagnoses in question. This way, I can have an active role in the education process, but I also gain a more complete understanding of why certain decisions are made and procedures/tests are done. But I have realized and accepted I still cannot have all the answers. Even physicians with significant experience and expertise must consistently work for these answers, sometimes still in the end unable to understand everything associated with a particular patient. We are human and also feel helpless when inevitably all possible therapies and attempts to promote health have failed in some situations. However, working through these emotions has helped me grow as an individual currently and while learning my limits throughout medical school. So I guess in summary, what we found in analyzing these student journals is that, and these narratives is that placing medical students in an unstructured clinical situation, focus on humanistic care that oftentimes made them uncomfortable was an effective strategy for helping them to learn to cope with uncertainty. And with that, I'll turn it over to Maria, who's going to talk about our last little bit here.
If I can get to advance. Thank you, Jeff. Thank you, Matt. Not stuff you expect to come out of third-year medical students' minds. And just give it a second. There we go. All right, Maria, You're up.
All right. Hey, everyone. I'm Maria. Thanks so much for having us today. So my perspective on the project focused on how provider and patient communication can ultimately improve patient experiences. Next slide, please. So just a little background. The provider roles have been increasingly focused on productivity and efficiency rather than on person-centered care, which is also known as the biomedical approach. And this approach can lead to burnout and depersonalization and less humanistic care. But there's also another model called the patient-centered model, which focuses more on this humanistic side of care. So this project ultimately focuses on hallway conversations and whether we as a healthcare team are missing out on important conversations. So an example of this is like a mother telling another mother down the hall that her other kids have been at home alone for 3 days. This is something that the team might never find out about. Next slide, please. So again, as the other students and Dr. Freiberg had mentioned, there were 120 narrative journals expressing student experiences. So these students were able to act as, quote, flies on the wall and listen in on some of these hallway conversations. And some of the emerging themes are really interesting. We found that students had to toggle between both the medical side of things and also shadow and interact with the families. They also could see firsthand how cancer really impacts all parts of someone's life, including things like family dynamics, school, the kids' social lives. And then the final sub-theme we found here was there was a pretty large dichotomy between the experiences of older versus younger patients. But the common theme overall was the physician-patient communication. Next slide, please. So this student had noticed the toggle between the listener and the medical professional. So they said, the waiting room was a place where I learned a lot. The first thing I noticed was that the patients tell each other a lot of information that they don't necessarily mention to the doctors. I observed 2 mothers talking with one another. They were essentially commiserating about the experience of not taking a shower for days and the tornado that they're feeling, that they feel they are spinning in when first diagnosed. It sounded like a therapeutic conversation. So this student noted that this was a hallway conversation that the healthcare team was in tune to, and they were just hearing things that the team wasn't finding out right away. Next slide, please. And then this student found out a little bit more about how cancer can impact the family life as well. So they wrote, I was able to briefly follow a patient in clinic and learn more about his family dynamic in regards to his diagnosis of both blank and blank. Long story short, this diagnosis tore the family apart and the parents' marriage ended in divorce. The mom had full custody of both children, but shared medical custody with her husband. The husband did not recognize their son's diagnosis of blank. He did not understand his son's pain crises. He believed that the son was making up his condition. This dynamic resulted in a very strained father-son relationship, and due to the legality of the shared medical custody, some of the son's care has been restricted due to the father refusing therapies and treatment options. So regarding this topic, the student really saw firsthand how the family dynamic crumbled and ended up actually causing more harm to the patient's treatment. Next slide, please. So this patient saw how cancer then impacted the siblings as well. So they wrote, there's a bulletin board in the hall right outside their door advertising a Super Sibs program for the siblings of patients. But upon closer inspection, that program is a summer camp they can attend. I talked to the nurses on the floor, and as far as they knew, there isn't a regular support program for siblings beyond the general support the psychologist offers. So they noticed that it was really important to include the siblings since they were often forgotten or left behind in this whole cancer journey. Next slide, please. And then another student found that cancer not only impacts the physical, but also the intellectual. So they wrote, the family said that during the last 2 months, they have had only 2 days at home. with the rest of the time spent in the hospital either for chemotherapy or complications. The patient was forced to miss so much school since moving to Pennsylvania that she will need to repeat 11th grade, further delaying her further aspirations. So these patients got really behind in school. They were repeating years, dropping out of college, and delaying their future aspirations. Next slide, please. And then cancer also impacts a person's relationships as well. So this student noted she misses talking to her friends at school and waits for the day to end so she can chat on the web with them. She commented on the timing of that diagnosis and that it came before a spring dance. When I responded that she has lots more to look forward to, she astutely murmured, "Yes, but that was my first one, and I'll never go with all my friends to our first dance together." So not only were these patients falling behind in school and academics, but also their childhood memories and social interactions with their peers were also falling behind. Next slide, please. And then the last sub-theme here was the age dichotomy that the students noted. So here again, I see a disparity between what it's like to be sick for the little kids versus the bigger kids. The younger child can play bingo and color pictures and hang out with her mommy and stay entertained to the point of exhaustion. The older child can't really eat, can't really talk, can't really get out of bed and do anything. And even if he could, there's not a lot for a teenager to do. You can't really simulate a normal life for them inside this place. Their friends are probably a pretty big part of their lives at this age, and it's too far for their friends to travel for a short visit. I'm definitely glad that the child life staff and the nurses and all the employees here do a great job of entertaining the young ones. I really am. I just wish there was more we could do for the older ones. So this was like a huge issue that a lot of the students noticed, that the older kids were having a tougher time through the whole process, probably due to the lack of social interaction with their peers and lack of age-appropriate activities. Next slide, please. So really, this project really boils down to patient and provider communication. So this novel elective allowed students to truly listen in on these patient interactions and hear these conversations that the healthcare team didn't necessarily listen to. So these conversations were found to be super important for patient experiences and treatment. And we saw multiple examples of this, from students hearing about how the family dynamic can really make or break a treatment, to how patients fell behind in school and their peer relationships. So the next steps we're really just thinking about how can we train current and future healthcare providers via this narrative style elective to truly listen to patient stories and conversations. And this is really in order to become, one, closer to the patients, but two, also to improve patient experiences and outcomes throughout their journey. And that's all I have on that topic.
So thank you, students, very much. They obviously did a lot of work on this. And as you can see, as I was reading these journals over the years, how they affected me, and it was a great opportunity to do this analysis and really pull it apart into these themes. So I want to explain where I want to go from here. So of course, the elective is still ongoing. This analysis went through 2019. We had 17 students in 2020, 22 students last year. So far, 18. We have one right now on the elective, and they're still turning in the journals. There is opportunities for more research. This was all qualitative, but there's quantitative things we could do. That there's a spectrum. The students did mention that some of the students just wrote medical stuff in the journals, and I'm not sure why. Maybe they misinterpreted the instructions. Maybe they felt uncomfortable with it. I really want them to be introspective and talk about things further along in away from just the medical part. So I'm trying to be a little bit more directive in the students. But there is an opportunity for quantitative research, some validated scales, word counts, student demographics, and so on, and see if that correlates with anything. One of the things we're really interested in, as these students wrote as if this affected them greatly. But the question is this just a short-term effect, or does it really stick with them? The goal is to have an elective like this stick with them so they have humanistic values for the rest of their careers. And we don't know that that's true. So we are initiating a couple of studies where we have a survey we've sent to the students who are still here who have taken the elective to see if they remember it and what they gained from it. And then we now have IRB approval, and we're developing a survey to send to students who took this elective as far back as 2018 and see if they remember it and see if it stuck with them. That's very important because it would really validate courses such as this occurring in medical school. I'm formalizing elective a little more. I don't want to make it too scripted. I don't want to tell them what to do each day. So again, the format and the length of the journal are up to the student, but I really want them not to give attention to the medical aspects. I want them to look at the at how it affects the patients, and particularly how it affects them. And I'm really looking for system issues and things like DEI issues if they come up. I want each student to meet with Dr. Blackall and our chaplain. They can attend psychosocial rounds. For those of you who have not seen the video, Why Charlie Brown, Why, I have the students watch that and we talk about it. And I want to incorporate a survey into the elective so that they get an automatic survey, say 3 to 6 months after, so that we can incorporate that in there, and the students will expect that they're going to get that to see what they remember. For my final thoughts, I have a quote, but this is not from the students. This is from me, but I'm going to read it. This kind of encompasses what I feel the elective offers. Experiential teaching methods paired with narrative reflection may be a valuable and therapeutic tool to learn the intricacies of the patient perspective, with the potential to enhance humanism in students during a critical time in their medical training when empathy tends to drift. This rotation illustrates the impact of teaching humanities in a clinical setting and promoting humanistic education at a formative time, planting the seeds of a humanistic medical practice early on. And of course, that's the goal. But what I really like to do, I mean, of course, the elective is only available to 1 to 2 students at a time. It's pediatric oncology, usually 1 student, sometimes 2 do it. And that means we can only get about 10 students going through this year. I really would like to adapt this to other specialties, starting in pediatrics, but I think that every medical and even surgical specialties could benefit from this. Obviously, it would have to be adapted to those specialties. It'd be very different in a consult service, say endocrinology or nephrology, something like that, versus an ICU setting. But I think any student going into any field, of course, these students who picked this were mostly interested in pediatrics. Some of them had heard about the elective and did it for that reason. But students going into any field could do something like this in any field in medicine, and even outside of medical school. PA students, nursing students could probably benefit from this as well. So what I'd like to do is reach out to other specialties, have them reach out to me, and I'm particularly interested in talking to young faculty who may want to get more into teaching and start doing more teaching, and see if they would like to adapt this for their own specialties, and probably start that in pediatrics. But you can envision a situation where all students would have to do a narrative medicine rotation in the field of their choice. I think it would benefit all of them. So I don't know if there are any questions for any of us, or actually I think Cheryl Dellasega is here as well. If anybody has any kind of ideas about qualitative research that you want to do, she's the one to go to. This is her expertise. If you don't know her, she's an RN PhD. So questions for any of us? Okay, Gail. Oh, that's not a raised hand. That's an applause.
I have a question.
Yeah.
So when how do you introduce the students to the families? Like, what are the kind of expectation from the families?
Well, that could be a little awkward at the beginning, but I'm just upfront with them. Some of the patients have had students before, and they're more than willing to do it. But it's most awkward when you have a new patient who doesn't even have a diagnosis yet. But that's the most valuable patient for a student. We talk about it before to make sure we think the student, the patient's a good one and the family's good. And usually we're correct in that. And I've had very little resistance from patients. They're usually very happy to have students there. And soon after they encounter the patient, they're doing play with the patient and talking with them, and sometimes giving the family a break. So there are benefits to it. But I will admit that the first conversation can be a little awkward, introducing a student who's not going to do any more than really just interact with you. But they usually appreciate it very soon after the encounter. And I think that's the most awkward part for the students as well.
Andy, other than meeting with Dr. Blackall, do they spend time with like music therapy, art therapy, child life, as they're interacting with patients?
Yes, they do. They don't do it out. I don't have them assigned to like spend time with music therapy, but music therapy, art therapy, pet therapy, all that comes into the room while they're with the patient. And a lot of the journals comment on that. But they don't participate on rounds, but they participate on rounds with that patient. So they're very much attached to that patient, but to the extent that all those therapies come in and interact with the patient, that's when they see those things. And that's when they get to see what they do, because they already know the patient.
If I could just make a comment, I'm not sure all of you know, but Dr. Freiberg was awarded the Clinician Educator Research Award this past year for the work that he's done. And I think he's been such a great role model for especially students who are going into busy clinical practice to show that, sorry about that, to show that you can still do research and you can still be scholarly and involved in things. And I really feel like his work is going to change. I call it applied humanities. I'm in the Department of Humanities, and I think his work has the potential to really change medical education in the future. So a big shout out to him, because it's not easy. It's not easy to add that extra thing to your workload.
Jeff, you had a comment?
Oh, I was just applauding. Congratulations.
I haven't actually seen the award. Cheryl had to pick it up for me, and she has it in her office, I think.
And a candy bar.
Oh. And also, this was my Harvard Macy project. I just finished the first week of Harvard Macy, and my project is to expand this to other disciplines. So that's my hope. If there are any other questions later, I'm around. So thanks for listening and watching.
Thank you for sharing. Great job.
Thank you.
Thanks, everyone.
There we go. Stop share. And okay. Diana, you're still there. Diana, you listening? Okay. All the way from Colorado, you get the award, Diana. Oh, okay. All right, bye-bye.